But she was driving me crazy.
I was going crazy with the oozing.
The oozing, let's talk about
Oozing.
that. All right, what about anesthesia? Well, we understand kind of what anesthesia is supposed to do. You're going to have surgery, and let's imagine you have to have a hip replacement. Or you have to have, something awful, a brain tumor, operation on your eye, or something, scary like that to me. You don't want to be awake. I mean, send me away. I do not want to be awake while somebody is sawing the top off my femur bone and hammering a new titanium nail down my femur and plugging that into my hip. That is something I do not want to have any recollection of. So we want anesthesia to work, and we use medications to put you to sleep for the time of the anesthesia, but also remember that the time after the surgery when you wake up is a time of potential pain because you've had cuts and tugs and pulls and damage and injury and things like that. So we don't want you to hurt afterwards. So anesthesia is a combination of a couple of things. One is the fast asleep during the time of the actual surgery while the hip replacement is being done, as an example, while they're taking out the brain tumor. And then what happens after you awaken? Okay, and so the anesthesia we use is highly specialized, very different than most anesthetics. We use drugs to help protect you from nausea and vomiting from the anesthesia. And you didn't have too much nausea and vomiting?
I didn't have any.
Good. So that's what we want. If you get the usual gas anesthetics that are most commonly used in the United States, gas anesthetics have an incidence of post-operative nausea and actually throwing up of about 30%. So if you give the gas anesthetics are great, but about a third of people, when they wake up, will feel nauseated and actually vomit, and that's no fun. The other disadvantage of the gas anesthetics is rarely the gas anesthetics themselves can dissolve into the fatty tissues. And when they dissolve into the fatty tissues, they can come out unexpectedly post-op and cause the patient to go back to sleep. And if it just goes back to sleep a little bit, there's nothing wrong with that. But if it depresses your breathing, it can be deadly, because then you can stop breathing, not get enough oxygen, and have an irregular heartbeat and actually a death. So we don't like the gas anesthetic, so we use a different kind of anesthetic that does not dissolve in the fat, does not depress your breathing as much, and doesn't cause nausea. So it's kind of helpful. But everybody's different, and we have a couple of funny stories about people's variable response to the anesthesia. And I want to preface this by telling you that you may have some experience with people having variable responses to sedatives. And that is, if you drink alcohol, or if you go to parties where people drink alcohol, you may have noticed that some people can drink a lot. Drink and they're still talking and drinking away. And other people, they drink a small glass of light wine and they fall asleep. And then the Irishman, he's drinking whiskey all night long and still talking. He drinks a fifth of whiskey. The other person can drink a tenth of that and they're out. Well, what's going on inside is the body is metabolizing the alcohol with alcohol dehydrogenase, and some people do better at that than others. And it's the same kind of thing as when people start injecting heroin and get addicted to it. You may know that the dose of heroin needed to get you high with heroin, not that you know this, but
I don't know that.
do you know that? No. What was your name again? You may know that somebody who starts off taking heroin may take a small amount so that they get high, but a long-time drug addict needs a whole bunch more heroin to get the same effect, because the body adapts. The enzymes inside of you that metabolize that drug change. And the same thing happens with alcohol, and the same thing happens with anesthesia. Some people have very powerful metabolic systems in their liver, and so we give them anesthesia, it doesn't faze them.
It fazed me.
Right. Then there are other people, and we give them just a little bit, and they fall out. Okay, so now, as you may know, we're in the West out here, and so we have a lot of members of the Church of Latter-day Saints, the Mormons, right? And they're not supposed to drink alcohol or coffee or anything like that, right? So what we have found is when we give anesthesia to our young little Mormon girls, boom, they're out. Okay. Now, I'm from the South, Southeast, and we have Baptists in the South, and the Baptists are not supposed to drink, but you can give anesthesia to Baptists all day long. They're not going down. So there's a difference in the response to the anesthesia. Okay? Some people get our dose of anesthesia and they're out. So I operated on a very high-ranking member of the IRS. The IRS. And she didn't wake up. So post-op, we went in to see everybody, and she was resting comfortably, and her vital signs are fine, but, hello, good morning, Miss So-and-so. So this is not going to be good for my taxes. And if you rubbed her chest, that's a way to test. It's a really painful stimulus. So you rub the chest. It's called a sternal rub. It hurts, and it wakes up even people with head injuries. It's really a powerful stimulus. She would, you go, you okay? So I'm going, this is really bad. This is really bad. About 2 days later, she finally woke up, and I went by to talk to her. I said, she goes, oh yeah, I'm very sensitive. I can't even take a cold tablet. I'm out. So I said, well, thank goodness you're back and nothing happened. You're very sensitive to medicines, but your surgery went great. And I made a mistake. I didn't stop her dose of Benadryl that we ordered. So she got another dose of Benadryl. After that, she was gone for another day. So some people, very sensitive to medicines, and they can be sleepy, and we like that. We can't stand the other situation. That's where we don't give enough pain medicine. We don't give enough anesthesia. And then imagine, have you heard the scary stories where people are having anesthesia and they're sawing off the top of your hip bone with the saw and you're awake?
Yeah.
Okay, so that's the opposite. That's the Irishman who is resistant, right? And instead of needing an ounce of anesthesia, needs a quart of anesthesia. And the most tragic situation would be, I need a quart of anesthesia and Dr. Rutledge is only giving me an ounce and I'm paralyzed. Because they use those drugs to paralyze you. So imagine the most terrible, terrifying situation. I'm in pain. I'm having this horrible, unimaginable pain. I'm wide awake from the pain. And I'm paralyzed. So that's the opposite. So you were a little too sleepy. The opposite would be you have the anesthesia. It's not enough. That you have that Baptist gene. You're metabolizing that alcohol.
I'm glad. I think I slept through all the...
You got the Mormon gene, right? You were out, right? Which is good. Now, what we do, though, is a couple things to allay your fears. Number one, you're not paralyzed. We don't use paralytics. So, if you notice that you're awake during the anesthesia, you can tap me on the shoulder. And I'll give you a finger gesture that you can give me that means that you need more. I won't show you the finger gesture now on TV. So if you're awake and you have discomfort, it's easy for you to let me know. Number two is, we use a kind of anesthetic monitoring that's not all that common. We put an EEG on your brain. Where they put those sticky tapes on and we can measure your heart rate? You've seen that on TV. And you may have seen on TV, if we put some sticky electrodes on your head and watch the electrical action in your brain, it's busy. You can see your consciousness. It leaves behind electricity. Like the beeping of your heart, you see all this waves. And as we turn up anesthesia, or if a person were to pass away, that line goes flat. There's no more brain activity, and that's gone. And then this is us, and we want to turn down your brain so that it gets sleepy, and it's not there. And so we give you anesthesia, but we also monitor the brain function with an EEG. Now, in a perfect world, you would tell me ahead of time if you were somebody who was either very sensitive to drugs or you're kind of like the Irishman. I need a lot more drugs. Okay? So I'll tell you a couple of stories. So one of my patients was on the operating room table, and I'm busy doing my stuff, preparing, laying out the lines and the cables and all this stuff. And the anesthesiologist does his stuff. And I don't normally pay much attention. He's breaking open vials and giving a drug and adjusting this and putting this on and placing this tube and all this stuff. And he's busy away, and I'm not, paying attention to that. I'm doing my business. And there's another set of bang, bang, blah, clack, click, just giving him, and then you hear him kind of this, end up breaking more vials and so finally, kind of comes into my that he's doing something. I said, "What's up?" He said, "Well, I've given her about 4 times the usual dose of anesthesia." And I looked over and I looked at her and go, "Hey, what's up?" She goes, "Nothing." So, okay. So anyways, we gave her a ton of anesthesia, right? And that worked and woke her up, and she did fine, and went out to talk to her husband and her daughter, who, you remember your son had a pretty heavy-duty bling? She was pretty heavily pierced with a lot of, skin art. Is that the right term? Right. So she was, and so I started talking about how Mom had been, and I asked, does she, ever drink alcohol? And they rolled their eyes. They said, "Oh yeah, she'd been in some drinking contest in New Orleans when they went there, and she had won over all these other people." And she said she can really drink, and that when she had her teeth out, she had been to the dentist. They gave her all these narcotics, and she said they didn't work on her. And I said, "Well, I think that's right. I see she can drink, and she metabolized the alcohol, and she metabolized our anesthesia." But interestingly, we recognized it and gave her 4 times the dose of anesthesia. Now, if she was one of those very sensitive Mormon girls who you give this tiny little dose to, you can't just give a high dose to everybody because they won't wake up for a week. So we adjust our dose based on the information we get back from your EEG. And that lets us kind of pick and choose and modulate that. Now, in addition, we use some different drugs post-op to help take good care of you. Okay? After you wake up, we don't want you to hurt. We do get some pain. Mr. Gibson, you had some pain?
Some, yeah.
Yeah, well, and we're worried about his pain. We do get some pain after surgery. We wish you had none. We wish you had none. Since you had pain, we don't want you doing a video today. No, I'm just kidding. No. So we don't want you to have pain, but think about this. Imagine that instead of doing your abdominal surgery, imagine that we cut off your thumb. You wouldn't be surprised if you woke up and the week after your thumb was cut off at surgery, if that was a little uncomfortable, right? That's raw and tender and sensitive. So we don't like you to have any pain. So again, post-operatively, we're going to give you medicines to try and help protect you within limits from the pain. Now you all, as we say in North Carolina, you all understand pain medicine pretty well. So you know that there are basically a bunch of stuff you can get in the grocery store. Aspirin, Motrin, Aleve, ibuprofen, Tylenol, acetaminophen. That's it, right? That's all the non-prescription drugs. And they don't work that well. They're for mild things, right? Help a little. The other drugs are narcotics. That's morphine and Demerol, hydrocodone, OxyContin, those kind of drugs. Very powerful, but also have 2 dangerous and unpleasant side effects. One is they can depress your breathing, and if you take too much, you can die. Okay, so that's serious. Too much narcotics, even though we'd want to take away somebody's pain, we're always worried about too much. The other thing is you can have nausea and vomiting. Have you ever had nausea and vomiting when you take codeine? Yeah, so codeine is a narcotic that's really well known for causing that nausea and vomiting. So we like narcotics, just like we like our anesthesia. We think they're good for protecting our patients from pain, But the side effect is that they're potentially dangerous and even deadly if they're used at the wrong time or the wrong dose in the wrong person. So they're not over the counter, obviously. They're dangerous. So there's a whole new area of research that very few people are using that we use called opioid-sparing analgesia. Opioids are narcotics. Analgesia is pain relief. And so to say that back in English is we want to give you pain relief without using a narcotic. So in other words, if the brain works because we gave narcotics, can we research around and find other chemicals, other drugs that give you pain relief that aren't narcotics and use them? And the answer is, yep. And I'm going to use a little bit of complex terminology, and I hope you'll forgive me, but I'm just showing off. No. There are two receptor systems in the brain that have been shown if we stimulate them, you could get pain relief. One is the N-methyl-D-aspartate receptor, NMDA, and the other is an alpha-2 receptor. And so we take our patients and we give them NMDA and alpha-2 receptor drugs to help them with pain relief without giving narcotics. Guess what the side effect of those drugs are? They make you a little sleepy. So, the patches that you had, those patches help slightly with the pain and the nausea. They're not terrific, they're not like narcotics, but they are alpha-2 type drugs. And then during the surgery, we gave you long-lasting medicine called ketamine, and that is an NMDA receptor, old-timey drug, that also helps relieve pain. And after a dose of ketamine, for a week later, it acts as an antidepressant. See it work. But anyway, so ketamine is an old drug. It's actually used as a horse tranquilizer.
Yeah, that's what she had to.
But we have found it's a good drug used as a small amount as part of our opioid sparing techniques. Brand new research on it, so I think you'll be interested. And that's probably why you're somewhat sleepy. Again, you're a little bit sleepier because you are more sensitive to the medicines. But we prefer a little sleepiness than to be wide awake and in pain.
I was perfectly happy with it.
So that's a long-winded discussion of anesthesia. Does that kind of answer some of your questions about the sleepiness and things like that? Other questions from anyone else before we stop the video on sleepiness, anesthesia, the medicines, things like that? I saw you guys, a lot of head shaking there on the Mormons. Okay, so you're not a big drinker? Not a lot of whiskey going down every night? Okay, so you might be someone that will use lesser dose, but I also saw you shaking your head when I was talking about being awake during anesthesia. So you're asking, if I'm going to reinterpret that, you can correct me, you're saying, number one, please don't give me too much medicine because I'm sensitive to medicines. But please don't give me too little medicine because I don't want to be awake for the surgery.
Absolutely.
And both of those things are, we think, helped by the type of anesthesia that we use and the use of that electroencephalogram. So we can monitor your brain, and we just kind of turn the medicine until your brain goes to kind of sleep. And they actually give it a number. Wide awake is 100, and 0 means no brain function, and we turn you down to about 20. It's kind of like cooking a goose.
Yours.
I have to edit that part out. I'm not sure that's... But we want the brain to be quiet and comfortable and relaxed and not wide awake, but we also don't want to give too much because those medicines have their own side effects.
Hi, I was told it was okay to embarrass you.
Oh, okay.
I just wanted to give you this.
Oh, no!
He's the best doctor I've ever had.
Oh, thank you!
I've had a lot of
No,
doctors.
she's only doing that because I have to redo your eyes. Thank you! Okay, and I'll get this redone for you.
Thank you.
Alrighty.